Hi, my name is Octavius Ferguson. I'm a third year Doctor of Pharmacy candidate, and I'm here doing a journal club today on ezetimibe added to statin therapy after acute coronary syndrome. This journal can be found in the New England Journal of Medicine. The objective of this was to evaluate the efficacy of ezetimibe added to simvastatin as opposed to the standard simvastatin monotherapy. The design of the trial, it was a double-blinded randomized trial with 18,144 patients who had been hospitalized for acute coronary syndrome. The location was 1,147 sites in 39 different countries. The inclusion criteria, the patients had to be 50 years old or more and had been hospitalized for acute coronary syndrome. The exclusion criteria, it excluded patients that had a creatinine clearance less than 30, active liver disease, or any type of kidney injury. Again, it was 18,144 patients, random. The primary endpoint was composite of death from cardiovascular disease, was a major coronary event, or non-fatal stroke assessed from the time of randomization until the first occurrence of one of the events. The secondary endpoint, composite death from any cause, major coronary event, non-fatal stroke, a composite death from coronary heart disease, non-fatal MI, or your urgent coronary revasculation 30 days or more after randomization, and a composite of death, CV causes, non-fatal MI, hospitalization for unstable angina or revascularization for 30 days or more after randomization or non-fatal stroke. Patients had a follow-up visits at a 30-day interval, 4 months interval, and every 4 months thereafter. Patients who had discontinued during the trial were followed up by means of telephone calls. Blood samples were obtained at randomization at 1, 4, 8, and 12 months, and yearly after that for those attending clinical visits. This study continued until each patient had been followed for a minimum of 2.5 years. The arms of the trial included a simvastatin with ezetimibe and simvastatin monotherapy only. Statistical analysis estimated 5,250 events were required to get a 90% power to detect a 9.375% lower relative risk for a primary endpoint with simvastatin ezetimibe than with simvastatin monotherapy. All efficacy and safety analyses were done in the intention to treat population. Adjustment of the level of significance to account for the 3 interim analyses was determined by the Land-Demetz approximation of the O'Brien-Fleming boundaries for a group sequential testing, with a final two-sided p-value for the significance of less than 0.0394. P-value of less than 0.05 was used for other endpoints. Estimates of hazard ratios and associated 95% confidence interval for the comparison between the two groups were obtained with Cox proportional hazard model. Event rates are Kaplan-Meier failure rate at 7 years. Baseline characteristics of the 18,144 patients that were randomized, 9,077 were assigned to the simvastatin monotherapy, 9,067 to the simvastatin ezetimibe group. The baseline characteristics of the two study groups were well matched. The primary endpoint: at 1 year, the mean LDL cholesterol level between the two groups was 16.7 milligrams per deciliter, which represented a 24% further lowering of LDL cholesterol when ezetimibe was combined with simvastatin than with simvastatin alone. Kaplan-Meier event rates for the primary endpoint was at 7 years were 32.7% in the simvastatin ezetimibe group and 34.7% in the simvastatin monotherapy group. Absolute risk reduction was 2%. The HR was 0.936, 95% confidence interval. The p-value was 0.016. The benefit seemed to emerge after 1 year. The rate of death from CV causes and from any cause was similar between the groups. Secondary endpoints was that the rate of each of the three secondary endpoints was significantly lower in the simvastatin ezetimibe group than the monotherapy with simvastatin group. The risk of any MI was significantly lower with the simvastatin ezetimibe group than simvastatin monotherapy. The p-value for that was 0.002. There was a non-significant higher risk of hemorrhagic stroke with the combination than with simvastatin monotherapy. The p-value for that one was 0.11. Even though the number of hemorrhagic strokes was low, the rate of composite endpoint of the death from cardiovascular causes, MIs, or stroke was significantly lower by 1.8% in the combination group than in the monotherapy. The benefit of the combination was consistent with nearly all pre-specified subgroups, and the benefit is particularly pronounced in patients with diabetes and in patients 75 years or more. Discontinuation of this study medication due to adverse effects was similar in the two groups. As far as adverse effects, no significant between the group differences were seen in the percentage of patients who had elevation in alanine aminotransferase levels that exceeded 3 times the upper limit of the normal range, or in the rates of gallbladder-related adverse events, cholecystectomy, muscle-related adverse effects, or new relapsing or worsening cancer. Discontinuation of the study medication owing to an adverse event occurred in 10.1% of the patients on the simvastatin monotherapy group and in 10.6% of those on the simvastatin ezetimibe group. The author's conclusion: the addition of ezetimibe to statin therapy in stable patients who had acute coronary syndrome and who had LDL cholesterol levels within guideline recommendations further lowered the risk of cardiovascular events. The event reduction was consistent with the predicted effects seen with statins, and no adverse effects or toxin effects were observed. The strength of this article that I thought was it had a large sample size, highly powered, similar baseline characteristics between the two groups. The weakness: the trial cannot prove that shown clinical benefit was due to lowering of LDL cholesterol alone. Results only relevant to ACS patients, large patient dropout, poor adherence. Follow an older guideline with recommended target LDL goals. Um, Adding ezetimibe to statin therapy in stable patients who had an ACS and who had LDL cholesterol within guideline recommendations further lowered the risk of CV events. Conclusion: according to the 2013 guidelines for cholesterol, individuals with a history of ACS are considered to have clinical ASCVD with high intensity statins, such as atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams, are recommended to prevent secondary ASCVD events. Sorry. Even though this study followed older guidelines, with target goals, the addition of ezetimibe to statin therapy was shown to be beneficial in the study by decreasing the risk of CV death. CV death causes myocardial infarctions and stroke. That's it. Thank you. Hope you enjoyed.